Thank you for joining us today. We're thrilled and privileged to welcome Micky Tripathi, the National Coordinator for Health Information Technology, whom many of you know and all of you know of. In terms of today's webinar, just a couple of brief pre-meeting notes. We are on social media and live tweeting the event. If you are interested in doing the same, our handles and hashtags are on the screen, and we are going to be muted for the first 20 minutes for the first 40 minutes of today's conversation, today's interview with Micky, and then we're going to turn over all Q&A to the last 20 minutes, and we'll open up the lines. We encourage you to raise your hand or to unmute your microphone at that time. We will make microphones controllable at that point in time, so we'll leave that last portion of the meeting open for your Q&A. Please take a moment at the end of today's discussion to complete our poll. It's brief, it will take seconds to complete, and we ask that you help us with that before we wrap up today. In terms of MHTC, very briefly, many of you know MHTC, many of you may not. We're the only organization of our kind in the country. We convene the health data community in Massachusetts, regionally and nationally, to solve problems that are better solved collectively than individually. Problems where competitive advantage is trumped by scale, is trumped by the rising tide lifting all boats, and the sheer cost of some of the changes that organizations in healthcare need to undertake. And the collaboration in and of itself enables that to happen much more effectively, much more consistently, and much less expensively. We bring expertise in health standards and regulation. We have a very local focus, but a national influence. And we are a proving ground. If you think of an organization like Da Vinci as a standard-setting organization where the cookbook is created, we are in some respects a test kitchen. We want to take what is being developed in interoperability, being developed in information blocking, being developed in the new API health data economy, and stand it up and to see how it works and to make sure it works for others. So we're proud of the work we do. We bring a number of benefits to folks who are members of our consortium, from the Vantage Point interview series that we're having today, to a data governance collaborative to support payers, providers, consumers, and others navigate the path from today to interoperability. We recently merged starting April 1. I got to get my dates right here. Starting April 1 with NEHN, the New England Health Exchange Network. So we are, in addition to being a collaborative organization, we bring a full suite of data services, not the least of which by any stretch is NEHN, which is a full standing information exchange with X12 for payers and providers, managed by the community. We have the forum, which convenes our technology leadership to solve problems that are near and dear to them and to raise topics that are of great importance to them. We provide educational and professional development through over 30 webinars a year, and we're delighted to continue that. And we provide an analytic solution or service, if you will, in Spotlight, which provides both clinical as well as administrative and market share and patient demographic data for health systems and others to conduct analyses of health system performance, both on the clinical front and on the operational front. So without further ado, I'm going to stop sharing. I'm going to unmute Micky and welcome Micky aboard. Micky Tripathi, thank you for joining us today. It's a great pleasure to have you.
Hey, Danny, thank you. It's just a delight to be here. And I just looked down the list of participants' names, and it's great to see so many familiar names. I really miss the Massachusetts community. Although I haven't moved very far geographically. I'm still in the same, still here in my study in Newton, Massachusetts.
Well, your background graphic belies that, but that's fine. We appreciate that what the web can do for us these days as far as making us appear where we are when we're not there necessarily, given our current circumstances. Mickey, as you and I talked about briefly at the onset of today, we're going to spend about 40 minutes talking with you. And the purpose of the Vantage Point interview series is to really talk with individuals like yourself who bring a purpose to the work they do. We're all heads down in data, we're heads down in standards, we're heads down in information blocking and information exchange, and it's sometimes absolutely essential that we raise our heads and look around and see the forest for the trees that we face every day. So we're delighted for you to be here. I thought we'd spend the first 15 minutes talking about your background, and then we can move to today and going forward. Tell us a bit about, let's start at the beginning. Tell us a bit about your growing up, your family, your community. So where did you come from, and why would we find you here after the background and the growing up that you had?
Sure. So I am very much a Massachusetts boy. Grew up, born in Worcester, and grew up in Chelmsford, Mass, right outside of Lowell. My parents were immigrants from India. They had bounced around a little bit doing their residencies. They came and did their first residencies in Springfield, Massachusetts. So literally got off a boat in New York City, got onto a bus, made their way up to Springfield Hospital in Springfield, Mass, and did their residencies there. They bounced around a little bit in different places. They were in North Dakota for a while. They were in Canada for a while, but they somehow, were really attracted to the Lowell, Mass area. They had done some work at Lowell General Hospital, which is where they finished out their residencies, and decided that's where they wanted to settle. So had a lot of deep experience going back in the Lowell community, in Lowell General Hospital in particular, where my dad was the chief of the medical staff, and my mom was a physician for the VA her entire career, a psychiatrist in Lowell as well. Also had seeing a couple of different sides of medicine growing up as well, where my dad was a solo practitioner. He was a general surgeon in family practice, back in the day when people did that, as a solo practitioner, and my mom working, in an enterprise, working for the VA, and seeing the differences between, what a solo practitioner, looks like in practicing medicine and what it looks like to work for a large organization.
Thank you. Your parents were both physicians. This must have informed your philosophy of work, what it meant to be working, what it meant to be leading. What did you learn from those that helped you as you were growing up? Who were the figures who helped instill in you a sense of purpose, a sense of this is something I might like to do, or this is how I might like to go about doing it?
I think, certainly, pointing to my parents, both of whom came to, the way they conducted their lives, or still conduct their lives, at least in my mother's case, and in the ways that they conducted their professional lives. I think I learned, a lot of lessons from both of them. My father was he was a solo practitioner, and so he was, building a small business like solo practitioners do, trying to carve out his space, and worked really hard with a lot of attention to individuals. And my mother was, working in the VA, working in a big institution, and having to work, within the structure of an organization that had lots of set processes, lots of policies, and was thinking a little bit more at a population level and at a people level. Whereas my dad, being a solo practitioner, was very much at the individual level before, this is way before accountable care and value-based purchasing and all of that. I mean, he was right. Very much one patient at a time. So, there was a lot of pressure for me to be a doctor, with both of them being physicians and being immigrants, and and a lot of push. And so I was on that path for really through senior year of college, where I was still doing all the pre-med courses, took biochemistry senior year, and then at the last minute decided that I didn't want to go into medicine. Really because I just found that I was more interested in working at sort of a policy level, and working at a higher level of sort of abstraction, and being able to work on policies that might affect more people rather than working sort of individually, one person at a time. I revisit that decision about every 2 days. I think about whether that was the right decision. But that was my thinking at the time. I also think that probably as I reflect on it now, there are lots of more opportunities for physicians to work in a wide variety of areas than there were back then. I mean, even back then, I assume there were broader range, but back then, the two mental models I had in my head were work for the VA or become a solo practitioner and work, in a small town setting, which is what my dad did, and he was making house calls, and those were my models. Is that if you're going to be a physician, you're going to be either one of those, and that's when I decided I didn't really want to be either one of those, and decided I wanted to work at a policy level.
So, as plain as it is, it struck me for the first time when I looked over your educational background that you indeed were a student of political science. You were a student of health policy or policy in general. Tell us about your education. Tell us who were the people when you studied, and completed your education with a doctorate at MIT. Who were the formative thinkers at the time who helped shape your view of the world, and what contributions you might make to policy? Who were the influencers for you?
Yeah, there were a number of them. So as you point out, I mean, I did, even though in college I was pre-med, I was a political science major. So I was still I was very much straddling that line. But I thought, well, I've got this real interest in policy, and even though I want to be a physician, so I'll do the pre-med sort of track and make sure I'm covering that, but we'll major in political science. And then I got out, and then realized that I really wanted to work in policy. So right out of college, I got an internship on Capitol Hill, working for a congressional caucus, and I was very interested in national security policy. And you may remember, you're certainly old enough. You and I are old enough to remember. This is back in 1970, or this is 1983, right? So the Reagan buildup and the nuclear freeze, and the Cold War very much alive, back then. And so I was, very interested in foreign policy and in national security policy in particular. So I went and worked on Capitol Hill for a year, half the year, with a congressional caucus called the Arms Control and Foreign Policy Caucus, where that was led by a woman who has since passed away, but a woman named Edie Wilkie, who was just a phenomenal mentor and leader. She really just, kind of really brought to bear the importance of, sort of working to get people to work together, and kind of instilled in me, that was the hard work, that there were lots of smart people around, lots of ideas around, but if you can't figure out how to connect all of that and get people to work together, then you're not going to get any of it done. And then I spent the second half of the year working in Senator Paul Tsongas's office as an intern, which was also a good experience. I mean, it was a big Senate office, and he was a very, even then, a very well-known guy. So not like I had, a huge amount of FaceTime with him, but that was, kind of formative working in Washington. And that's when I decided that I, really was going to, try to spend more time working in Washington, the federal government. So I came back. So I spent that year, applied to grad school, went to the Kennedy School in public policy, and studied public policy there in the MPP program. Again, focused on national security policy and in quantitative methods. So I was also very interested in economics. So worked in economics, but all with an eye toward national security policy. And coming out of the Kennedy School, then I became a presidential management fellow and working in the Pentagon. And that's where I spent a considerable amount of time working in national security policy in the Pentagon. First with the in the Air Force Controller's Office for a couple of years, and then moved over to the Secretary of Defense's office, where I was for 4 years working on Marine Corps programs, in particular tactical aircraft, amphibious warfare, all things that people may be surprised to know that I actually had a fair degree of expertise in that for a while. But then then I decided that I didn't really didn't want to spend the rest of my career working in defense. We also had we started having kids. I met my wife in Washington, although she was from Massachusetts. She's from Andover. And as we started to have kids, we just, we decided, all right, we're gonna have to make a decision, which is we either decide that we're gonna be here in Washington, and because you easily get trapped in it. We were both civil servants. We bought a house in Bethesda, and it's like, well, if we just keep doing this, we'll have made a decision just through the momentum of federal service that we'll just be here, or we need to make a proactive break and say we want our family to be in Boston. And so both of us just decided we want our family to be in Boston. So that's when I left, decided to go back to school, and that's when I went to MIT and worked in political science and economics. As you can tell, I can't stick to one topic. every part of my educational experience was, well, let me do a little bit of that and a little bit of that. So I straddled the political science and the economics departments at MIT. And my original thought was that I would teach. I did a couple of years teaching statistics and econometrics at MIT, which I really liked. But I already had 3 kids then, and as I started to think about the job market, realized that I was very foolish in thinking that I was going to go into a teaching career, given the entry salaries for starting professors, and the fact that you would have to, there were much smarter classmates than me who were taking their first jobs in places like Arizona and Wyoming, which is, there's nothing wrong with those states, but I definitely didn't want to be taking my family out to Arizona or Wyoming. I really wanted to be in Boston. So anyway, that's how I realized, all right, we need to have a change of plan here. And this was around the time of the dot-com era. You may remember, where there was a huge, sort of uptake, particularly in consulting. And the major consulting firms were recruiting very heavily on the Harvard and MIT campuses. And I stumbled into one of the introductory sessions that the Boston Consulting Group had, introducing people to
join the meeting.
And so I ended up applying to work at BCG, and was fortunate enough to get a job there. And that's how I ended up sort of making the transition away from government service and away from academia.
And to healthcare, to Indianapolis, Indiana. You're out of government, you're in the private sector, you're not in Boston. I mean, you're able to come home, I assume, every week as consultants like us did then. But you found yourself in Indianapolis, working for starting up the HIE in the state of Indiana. Can you share a little bit about that with us?
Yeah, absolutely. So yeah, I mean, as you point out, BCG, especially the Boston office, which is, of all BCG's offices, is the highest travel office, and BCG was already a high travel firm. So I spent 5 years out on Monday, back on Friday, week on week. And though I was in the healthcare practice, that's a pretty wide swath of industries, really, when in management consulting. So I did a ton of work in the pharma industry, worked on a bunch of mergers, the Pfizer Pharmacia merger, GlaxoSmithKline, a bunch of others, and then did a lot of work with some bioinformatics firms and a couple of other firms, and then ended up working out in Indianapolis. So we were hired by a group out in Indianapolis called BioCrossroads, which is it's an organization that gets together private industry organizations that each year make investments in the community to try to improve the business climate. And they had actually seen something in Massachusetts. So they had seen a pro bono study that BCG had done for the Massachusetts High Tech Council, that the Mass High Tech Council had up on their website, which was about how you can get synergy where academia, industry, and government work together. And it was a showcase of Massachusetts, but it was really sort of looking at different places and saying that that in areas where you can find that kind of synergy, it can really be a real leap forward for for a local economy. And so they saw that report, and so they reached out and and asked if BCG if we'd be willing to come out to Indianapolis to just do an industry scan and see where there were any such opportunities. In Indianapolis, where you have those three things: academia, government, and private industry having deep skill set and deep interest in some specific areas. So I wasn't a part of that initial team, but that initial team came back with 8 ideas for for things that they thought really got traction. One of them was called evidence-based medicine, and it was based on the work that was being done by the Reagan Street Institute. So this was like the year 1999 or so, or 2000. And so they, that was one of the areas they identified. The BioCrossroads group, took all of that, read it for 6 months, and then came back and they said, there are 2 of these that we would actually like to fund with, with a no kidding business plan. And one of them was a proteomics center, which ended up getting funded and capitalized, and I think is still alive there. And then the other was this evidence-based medicine thing. And that's where I had the good fortune of being asked to be the project leader, to go out and lead a team to write a business plan for this fledgling business, which turned out to be the Indiana Health Information Exchange. So that's how I got involved in Help IT. As I went out there, again, week on week, I was commuting to Indianapolis essentially for a year and a half, where we worked on creating the business plan. So walking around, doing everything you have to do to create a business plan for this fledgling business, and then we gave them the business plan. They came back and said, we'd actually like to capitalize this, and asked if I'd be willing to be the CEO. I really, even though I practically lived in Indianapolis, I really didn't want to move there. So we worked out an arrangement with BCG where I could be an executive on loan for a year, just to get the organization up and running, to be the fiduciary CEO. But then, most important to me, to find my successor. So I spent a fair amount of time trying to, convince, and ultimately successfully convincing Mark Overhage, who many people may know as, a luminary in the field, convincing him to, take over in my place once I was able to leave.
Great, thank you. We know you at MHTC through the work of the Massey Health Collaborative, and many of others know you from that work as well. But I want to move at this point to where you are today. You have started this new role right in the middle of a pandemic, and could you talk a little bit about, how the pandemic changed or altered the trajectory of the ONC? What were the priorities that were suddenly thrust in front of you that had to be taken care of? Planning and timetables notwithstanding, there was a national crisis and international crisis, and the ONC had an important role to play in that. Could you share a little bit about that?
Sure. Yeah, happy to. So, I think there was, this is a very unusual start to an administration and to a head of any agency, and certainly to the head of ONC. And I think there are a couple of things at play there. Certainly one, was just, the pandemic and everything related to the pandemic, and that being job one for everyone, to figure out how each of us, and regardless of which agency we're in, can contribute and help toward getting the country past the pandemic. It also is the case that I think it's probably not too controversial to say that there was somewhat of a rocky transition between the previous administration and this one as well. And so so that put a high premium. Both of those things put a high premium to getting as many people in place as possible as early as possible. So normally you might have a process where the secretary would be named, and the secretary would then be able to name their some direct report to the secretary as one of the staff divisions. And normally you would have that kind of process. In this case, I think because of those to those two things that I just described, there was, a very, sort of proactive strategy to say, how do we identify the most senior people who do not have to go through Senate confirmation and get them in place as quickly as possible, so that we have as much of the top leadership as possible to be able to hit the ground running, knowing that, and as you may recall, in December, Georgia was still in play. It still wasn't sure, where the Senate was going to land. So there was a lot of uncertainty about how is the nomination process going to work and how long is it going to take to get, some of the, the most senior leaders in place. So there's a big push to get, to get as many of the most senior people in place, as possible. So that meant that, that I was a day one employee. So yeah, as the Constitution defines, on January 20th at noon, I started at 12:01, and there were only a few of us. There were only a few of us there at the time. I mean, Francis Collins, who's the head of NIH, was he's got a different kind of appointment that is coming from the previous administration. And Rochelle Walensky from the CDC is another senior person who doesn't require Senate confirmation, and so she was in place. But for the most part, we were the only ones who were there as the senior political leaders. Now that's obviously now all filling out, which is great. So that there was a lot of that pressure, I think, to get things in place as quickly as possible. And then in terms of responding to COVID, a couple of things. One is there's we're not an operating division like the CDC, the FDA, NIH. Those are operating divisions. We're a staff division. And so, which means that, we're not doing provider or patient facing things typically, sort of that much, or delivering services on the ground. So in terms of the COVID response, the CDC obviously is going to be much more involved in things on the ground operationally, working day to day on certain things. But we did work on a number of things that, that were very tactical in nature, some of them, and some now that are more strategic in nature. So, early on, tried to identify opportunities for saying, how can we, sort of inject the use of standards in ways that might accelerate certain capabilities that are, rapidly being put in place now, and that will also set us up for the future. So scheduling, for example, we're now at a place where supply of vaccine, is far ahead of demand. So, so we don't have this pressure anymore. But early on, there was a ton of pressure as, everyone was trying to, do scheduling. And so we did a bunch of work pulling together, working with our partners at the U.S. Digital Service, pulling together, kind of a coalition of the willing to implement a FHIR-based approach to integrating their systems with the vaccines.gov, website, to be able to make available appointment availability, for example. That was going off in a direction of custom standards and a wide variety of mishmash of things. So, we did a ton of work, again, not through regulation or anything, but just through cheerleading, encouragement, begging, pleading, to get people to say, hey, can't you just base it on FHIR? Because if you do that, that'll set us up for good things in the future. We also did some work in thinking about vaccination credentials, which of course the federal government is not going to be doing anything related to vaccination credentials, but certainly to the extent that the market was going to be doing anything related to vaccination credentials, we wanted or had an interest in saying, if that's aligned with the standards that ONC is promulgated and is putting into electronic health record systems, that'll make everything work better. That'll make everything work better for providers, for health IT developers, for patients. So did some work there, and in thinking about how the smart health cards approach, for example, could be something that could be adopted across the industry. And then the last thing I'll point to with respect to COVID is, and this is a little bit more of the strategic rather than the tactical, is we're co-leading a cross-agency work group that is working on one of the executive orders, the executive order on ensuring a data-driven response to high consequence public health threats. And we're co-leading that with the CDC. And that's looking at what have we learned from the pandemic with respect to public health data systems? How do we identify those gaps? And then what do we then think about, that suggests for a strategy for investments in public health dollars going forward? And so that's a ton of work that we're focused on. We got a number of ONC players. We've got our advisory committee engaged in that, and we work, on more than once a week basis with the CDC on, on gathering that information and starting to think through, what the next steps are there. I mean, in general, I think of that as trying to, say, how do we get us from public health data systems, which are siloed and separate and one-way static report kinds of mechanisms, to a real ecosystem where we don't think about public health as being really different from the clinical care ecosystem, that they're all part of the same ecosystem. We have a much more modern, sort of approach to dynamic availability of data, bidirectionality in terms of information flows, as well as functionality, being able to say, how do we, have public health, sort of knowledge and analytics that can get fed back into provider systems so that they can take local actions, based on, higher level information aggregation and analytics.
Thank you. Interoperability and standardized data, such as the US CDI, the US Core, are means to multiple ends. Would you talk about how interoperability will address two issues that have become critical issues in just the last year, if less time than that, and that is health equity, and for maybe a longer period of time, clinician burden? Could you talk a bit about how those have come to the forefront in
Sure.
a relatively short period of time?
Yeah. I mean, health equity is a huge area for us at ONC, and we haven't, sort of figured out exactly what it means yet. But I can, certainly say that we're doing a ton of work in trying to figure out what that is, and hopefully we'll be able to share more on that, a little bit, hopefully in the, by midsummer, toward the end of the summer. And, we kind of do that under a concept that we call health equity by design. Which is to say that we should be thinking in a more fundamental way about our health IT systems. And that goes from standards to actual implementation of systems, and to what functions you want to be able to get out of those systems in a way that, bakes in the, sort of, the presumption that you need to be able to identify and flag where there are health equity issues, and then be able to generate information that can help people to rectify those, not in an afterthought kind of way, but in a way that is, sort of baked into the way that the systems are designed. So there's, a lot of work to think through about what that means, but that's, sort of the high level concept that, that we're working on. But getting now to, to the more specific question you asked then, as we think about, health equity and clinician burden, I think there are, a couple of different angles on that. One is, obviously the work, using the levers that we have, things like the US CDI, which you had mentioned, the US Core Data for Interoperability. We've got the version 2 of the US CDI coming out this summer, and we're giving a lot of thought to how we, start to include more equity-oriented data into the US CDI. So, we'll have more to share once we're able to make that public, but that's, that's an area of, great and deep thought about, about how we do that. And I will say, just as a small aside, we got a tremendous amount of experience and learning, or I certainly did, from the work that we did in Boston with the Boston Public Health Commission and the Boston Health Equity Measure Set, which I actually don't know where that project is. I hope it's still very much alive and hopefully on the verge of thriving. But with the team at the Mass Health Collaborative, I think we were able to get a lot of learning about how you can think about, getting that kind of data and what the challenges are in that, and hopefully what the benefits of that could be once you're able to get it. So it starts with being able to, make sure that that data is collected and available, and then flows through the system in a way that allows you to make, appropriate decisions. I think, one of the challenges, and this relates to clinician burden, is that, for the US CDI, and equity data is one aspect of that, but there's other types of data, is also just trying to be very cognizant of the fact that we can add more and more data elements to the US CDI, but every one of those data elements is a corresponding burden on an individual, on a person, to capture that data, document it, for an IT developer to capture it, in a standards-based way, and to be able to, sort of manage it and handle that data in a particular way. So, I'm trying to, sort of give a lot of focus with the team to saying, every data element we add, we better have a good, clear line of sight reading for what value is that adding, and where is it adding value to,
Right.
To the overall enterprise here, so that we're not just dumping a whole bunch of data requirements on people, where we don't have good visibility into, into why they're doing it, because that's the minute that we lose them as well. So that's a big part of it. I think the other thing, and very specifically related to clinician burden, is that we have a whole team. We have a clinical team who, and clinical burden is one of the things that they focus on. We work a lot with the Office of Burden Reduction at CMS. We've got a report called the ICADS report that came out earlier in the year related to clinical administrative data and reduction of burden as you think about that. And we're going to have a version 2 of that coming out later this year. But we also think that the move toward a platform-based approach as we think about electronic health record systems, based on RESTful APIs, based on the ability to have apps and pluggable apps that can improve the user experience, are ways that we can get better usability that is hopefully a reduction in burden to people. Because one of the challenges that we always hear is that that the systems are difficult, and that in and of itself is a burden or a source of burden. And to the extent that we can work on things like being able to say, well, we can bring in a set of apps that can be configured in a way to give you a better user experience and can be a little bit more lightweight and tailored to your needs, that hopefully can be a part of the solution there. I think one of the big challenges also, and this is the last point I'll make on this, is that that a lot of what is blamed on the EHR systems, I think, as we may know, are actually burdens that have come from others who use the EHR as a conduit for greater documentation requirements by payers and prior auth and a whole bunch of other things that come in that the EHR gets blamed for, but are actually about people using that as a vehicle for for things that they didn't use it for before. So we're doing a fair amount of work there to try to figure out how you can kind of get the right balance as you think about that.
Great. I have one more question to ask before we open it up to questions. The consumer is at the heart of the new model, if you will, the new health ecosystem where providers and payers are sharing data. Payers are acting as a conduit through which consumers will have access to their full health information. But some people are skeptical about the notion of the consumer as a force. Probably those of us who are older, I would say, is one way of segmenting that population. Not that I feel that way necessarily, but there are industry observers who are skeptical that the consumer really wants to do this, or that the consumer will be able to do this, and that they will become a market moving force. How do you think, what are your thoughts about consumerism and consumerization in healthcare? And where do you think it will land as opposed to, say, how it manifests itself in consumer products or financial services? It's going to be different in healthcare. How do you see it? How do you see consumerism playing out as best you can? This is a bit of a crystal ball, but just from your vantage point.
Sure. Yeah. No. At a personal level, I'm an old guy too, so I share some of that skepticism. But that said, I think from a policy perspective, I don't think that should diminish by one iota our urgency and energy in making that data available to individuals. So I kind of hold both of those thoughts in my mind, that I don't think that just making the data available to consumers is going to solve the interoperability problem, because now they can be the conduit, or as someone once called it, having consumer be the data mule for all of this data. I don't think that I think that it's still an open question. How many consumers really want to be in that position? And then to the second point of, can they actually make good use of that information? Again, I don't, I think that we can, sort of keep those in two, parts of our mind to say, still unclear where that's going to happen. How many services are truly shoppable? How many people really want to do that? How many people are really able to do that? From the absolute obligation that we have, certainly from a federal government perspective, to say we need to do everything we can to make as much of that data available to them so that they're able to do that if they want to. And that there's a whole bunch of other benefits that can come from that, from just opening up that avenue. So that's kind of where we are in saying that we cannot slow down in any way, shape, or form that push to make that information available, even if it may not have sort of the full market implications that we think. I do think that there are lots of ways that that's going to open up opportunities that, that like with anything in innovation, there are all sorts of things that happen once you open up different avenues that are really hard to anticipate. Once you get so many different people involved, such creativity, all of a sudden there are things that you never in a million years would have thought of, business opportunities, value creating opportunities. And I think that the opportunity for the healthcare sort of spectrum, or the care delivery or the care continuity spectrum, to be expanded in a way, because there are a set of patients who may choose to exercise their ability to have that information, and that allows payers, providers, others to engage patients before they actually are in an acute setting, or before they're in the physician's office, in a much more continuous way throughout their life journey. That strikes me as being something that's really probably important and fundamental, that could be market altering. That's different than saying that consumers are going to choose their cardiologist like they choose cereal.
Yeah, like a CD at a bank or something.
Right. Yeah. So in that, but I do think that there's some fundamental changes in the way all this comes together that really could be opened up by making sure that information is available.
Terrific. Okay, we are now at just about 15, a little more, fewer than 15 minutes before the hour. I am now going to open the lines for questions. So if folks will give me a moment, I will allow you to unmute yourself. I will also allow the chat to be available for folks if they want to type in a question. We have approximately 12 minutes left in our conversation with Micky Tripathi today. If you have a question to ask, please raise your hand. I see we have a question from Janice Karen. Janice, what's your question?
Yes, if we have time later, I have some additional ones, but let's start with, do you see an ONC role in efforts to expand health data interoperability beyond traditional healthcare settings, such as into school nurses' offices, homeless shelters, food banks, gyms, senior centers, and the like?
Yeah, that's a great question. So I think there are a number of ways that, so the short answer to that is yes. I think the longer answer is, what are those ways and what are those programs? I would just point to two. One is we're doing a lot of work in social determinants of health. We're working with the Gravity Project, and we have a whole program and project that we're launching within ONC to think more broadly about social determinants of health. And obviously that's starting to get at the data that exists out beyond the healthcare setting and in a wide variety of settings that are non-traditional, but that are an important part of the social service network that's out there. And that also then begs the question of how is information get fed out to those organizations under appropriate set of circumstances. The second is TEFCA, the Trusted Exchange Framework and Cooperative Agreement, which is the nationwide governance sort of mechanisms that was defined in the 21st Century Cures Act that we're working hard on. And we have a whole part of thinking about what are permitted purposes that would relate to entities that aren't covered by HIPAA, and how might that work. So that would be another avenue for thinking about how that could be sort of a place for entities that have traditionally been left out of those networks to be able to participate.
All right, we have a couple of questions that have also come in across the transom from Hugh Byers. Any thoughts or comments about the NASEM, NASEM's initiative on primary care and their coming requests of the ONC?
I'm sorry, I don't know much about that.
I understand.
Happy to say I don't know something. I'm happy to get back to Hugh if he wants to reach out offline.
We'll save that question. We also have a question from Claudia Boldman. It's good to see you, Claudia. And she says, it's great to see you again, Micky. Is ONC involved with CISA in addressing the ransomware malware problem?
Yeah, we're not directly, although, we certainly have a whole technical team, excuse me, that's, obviously has, security as one of the things they look at. But we're not directly involved with the CISA on that right now.
Okay, and let's see here. Is ONC, this is from Bob Rudin, and I will follow this with Bob Dichter in just a moment. Is ONC planning any demonstration projects for emerging standards, such as the social determinants of health standards?
So we don't have any, it depends on how you define demonstration projects. So we have a wide variety of grants that we have with HIEs and others around a wide variety of things. And I'm sure that we have some related to social determinants of health. I mean, certainly if you want to reach out to me separately, I can point you to some of those things, but we have an SDOH workshop coming up. It might be the week after next. And I can certainly get that information as well, which will be an open all-day workshop where we start to think through, and I think there might even be one tomorrow, if I'm not mistaken, but there's one, a week and a half from now, where we're going to be really diving in with, with a variety of players from the industry to start to think through, how we move forward the social determinants of health agenda.
Thank you. Bob Dichter, you've raised your hand. What question would you like to ask?
So first of all, thanks very much, Mickey. This is always a pleasure listening to you.
Hey, Bob, great to hear your voice.
Good to see you, man. So on information blocking, a topic that I know you're near and dear to you because I've seen other interviews on that you've done about it. What advice do you have to the physician community who is scratching their heads saying, what do I need to do about this? Is it my vendor's problem? Do I need to hire a consultant? My vendor has told me that they'll make sure the data is available on the portal, but I think it's more than that. I think I need to make sure I'm doing something else, but I really don't know what I don't know. What's your simple advice, or maybe it's not so simple?
Yeah, I mean, there's the simple part and there's not so simple part. So, but thank you. That's a fantastic question. I think it's, some of the short response is it's not something that you can just leave to your vendor, because the vendor is just required to make available the technical capabilities. But, information blocking is about behavioral changes. It's about fundamental behavioral changes in the way we think about information sharing. We're moving from a world where organizations felt like, well, I'm only going to share information unless I decide that I have a really good reason that I've convinced myself that I need to share that information. And I'm obviously making that sort of an extreme case, but that is kind of a little bit of the attitude as we think about it, to a world where, and this is not coming from ONC, this is baked into the 21st Century Cures Act, which was signed by President Obama in 2016, that says that everyone needs to move to a world where you think about your obligation for sharing information unless you have a darn good reason not to share that information with authorized parties. And that's what the ONC rule does, is it specifies what are those darn good reasons, and there are exceptions listed there. So there's fundamental changes, Bob, to the question, that you're asking in the organization itself, I think, in the way it thinks about how does it release information? When does it make information available? How does it make itself responsive to requests from patients, to requests from other provider organizations, to requests from payers for that information? So I think that's a whole part of it. The other thing, though, that I really would strongly encourage everyone to be thinking about is not the compliance part of it, but the opportunity part of it. Everything I was just describing about is how I need to make information available to others. Remember, I hear so many complaints, and I've heard them over 20 years, about I can't get information from those other places. Well, that's what information blocking is about too. It's all those other places, those 10 other organizations that you always felt like you couldn't get information from. Now you have the opportunity to use this strategically to say, there's now an obligation on them to share with me, and how do I move as quickly as possible and, sort of changing my behavior about the way I make information available, but also the expectations that I create in my organization to reach out and get that information from others and work with my vendor to get those capabilities in place and establish the workflows to be able to do that on a more and more of a routine basis. I know that's a lot of work. It's absolutely a lot of work, but there's no way for us to completely change the paradigm of interoperability without people doing hard work. I just don't think that there's any way for us to get around with it and get around that.
Thank you, and thanks for the question, Bob. Kathleen Snyder, you have a question. If you unmute yourself, please ask it.
Hi guys, hi Mickey. So great to see you and hear your voice.
No, you too.
So I'm now at a law firm where I support a number of these app developers who are really looking for creating the innovation that you spoke about to help ease the burden, before folks get into an acute setting. And I'm wondering, are you guys at ONC doing any coordination with CMS for the reimbursement aspects for, because that's a question I get, like, well, I have this great app and how do I get paid for it? Because it's not always a reimbursement model that is just supported by the membership, the direct to consumer. So I'm wondering if there's any thought process or coordination between you and CMS on the reimbursement piece.
Yeah, absolutely. I mean, that's like an ongoing, every single day, every single minute, kind of conversation that we have. So just to back up a step, with ONC, one of the things that I quickly discovered in taking this job is we're really a service agency to the other federal partners, which is to say that, we work with them to say, it's almost not so different than when I was at BCG, actually, is trying to identify from the business owners like CMS, like the CDC, what are your business goals that you're trying to accomplish? And then how do we help you identify health IT using standards, other kinds of things, interoperability, to help you then bake in those capabilities and supported by a reimbursement model, because as we know, none of it's going to be sustainable, outside of that. So, the answer to that is, yes, we work with CMS on a day-to-day basis, but it's always on something functional, right?
Sure.
And that's the thing I think is the key, is figuring out, well, what does that app do? What is it actually doing that's going to be valuable to CMS? And then, and then there's a way to think about, reimbursing for that activity, not for the technology itself.
Absolutely. Well, thank you. And again, great to hear you and see all this great progress.
Thanks, Kathleen.
Well, we have time for one more question. We're approaching the top of the hour. Yael Miller from the Medical Society asks, first, she says, it's nice to see you, Mickey. Where will the next 5 years lead us with interoperability rules in place? And what new rules do you see coming down the pike? What barriers are you anticipating? It's a big question.
A big question from Yael, who, I know always has big questions. So, yeah, a couple of things. One is, where do I see us in 5 years? I mean, if we can get to a place where, going back to, something I said before, where people start to think about the, sort of the strategic opportunities that they have, in using, APIs, platform-based approaches, and a collection of apps that serve their needs, and help them get to the next level of, delivering value for themselves as well as for their patients. That's, to me, is a huge part and a huge accomplishment of this. So we move past the compliance part of this and we've moved to the next level. Second thing I would point to is that we start to fully embrace the opportunities for non-standardized and non-structured data, because, for those who follow the information blocking rule, I know each of you knows it in great detail. Right now, the requirement is for you to make available as a provider organization or a technology vendor or a health information network, the US CDI. So the structured data is your obligation in terms of what information are you required to provide under information blocking. But on October 6, 2022, that opens up to the general concept of EHI, electronic health information, which is supposed to be everything, and I'm putting that in quotes, in an electronic medical record. It's kind of like the electronic version of the designated record set. And that begs the question then of, what am I going to do with that information? And, and that was very much a deliberate discussion, and decision to say, we can't wait for the information to be standardized in order to make it available. Because if we wait, that's going to take too long. So that's going to be the next opportunity. And I hope that we're in a place 5 years from now where people are really starting to embrace that. They're starting to say, I am now getting EHI from these different places. I have built algorithmic machine learning, other types of capabilities to be able to make, better use of that. And then the last thing I would point to is TEFCA. Hopefully by then we have TEFCA up and running, and that is seen as an enabler of more sane interoperability across the country.
Well, we have many other questions, but we are out of time. And I want to thank you, Mickey, for joining us today. It's always a pleasure to see you and to hear what you have to say. I want to thank you on behalf of the consortium and of our members, and for all the folks in our community who were able to join us today. We
Thanks.
wish you well, and we will come back to you with other questions as we near the end. Just before we do wrap up, I'm going to launch a poll here for the folks who are still on the line. We're going to keep this poll up for the next 30 seconds or so. So those of you who are not fleeing to other meetings, allow us a few moments to capture your information. Oh, they're coming in fast and furiously. This is excellent.
Well, it was really a delight to be here, and with you, Denny, and the role MHTC has played over the years and continues to play is just extraordinary. And for everyone who's still on the phone, please feel free to reach out to me anytime. You know where I live. Many of you literally know where I live, but please reach out to me. We're always happy to to talk individually and connect you up with my team if you have specific questions where we can be helpful.
Terrific. Thank you, Mickey. Thank you to your team. And thank all of you who have joined us today. We're adjourned.
Great. Thank you.